Good morning, good afternoon, and good evening, depending on the time zone you are in. Welcome to the scientific session on the crucial role of rapid diagnostics in the early detection of secondary bacterial and fungal infections complicating COVID-19. I am Dr. Aparna Ahuja, currently the Chief Medical Officer at T2 Biosystems. I provide leadership and strategic direction for all medical, clinical, scientific, and regulatory affair activities. I'm a strong advocate of patient and healthcare worker safety with a career of almost 3 decades in laboratory medicine and medical affairs in medical device in vitro diagnostics. I'm an advisory board member of Pain Care Labs US, corporate advisory board member of AECC, CLSI expert panel member, trained inspector with CAP and ISO 15189. I would now like to introduce the speakers of our session today. Dr. Thomas Walsh Md, PhD. He has board certifications with American Board of Internal Medicine, boarded in internal medicine, infectious diseases, and medical oncology. He is the professor of medicine, pediatrics, microbiology, and immunology at Weill Cornell Medicine of Cornell University, New York, USA. He is also the attending physician at the New York Presbyterian Hospital and Hospital for Special Surgery. He has education and training at the Johns Hopkins University School of Medicine, US. Dr. Tamara Seitz, MD, is specialist in infectious diseases and tropical medicine at SMZ Sud, Vienna. She did her MD at Medical University of Vienna and doctoral program of Applied Medical Science, Public Health, Medical University of Vienna. Patients diagnosed or suspected of COVID-19 have a risk of bloodstream infection, increased risk of secondary infections, sepsis, and septic shock. Sepsis is a burdensome condition worldwide in terms of morbidity, mortality, and healthcare costs. Sepsis is the body's extreme response to an infection and is potentially life-threatening medical emergency. Treating secondary and co-infection in timely manner is important, as early treatment improves chances of survival. Overdiagnosis becomes acceptable as overtreating appears less harmful than missing secondary infection and sepsis. This leads to overuse of antibiotics for COVID-19 patients, driving costs and resistance. Sepsis represents $62 billion in US healthcare costs, claims more lives each year than 3 leading causes of cancer deaths combined. Estimated 49 million cases and 11 million sepsis-related deaths worldwide, which accounted for almost 20% of all global deaths. Secondary infections and antimicrobial resistant infections are likely to occur in clinically significant proportion of hospitalized patients with COVID-19. Preliminary studies suggest co-infections are common, especially in severe cases with highest risk in critically ill patients. You can see in the figures on this slide demonstrating types of co-infection among COVID-19 patients from Wuhan. Over 25% of hospitalized patients had co-infection, out of which around 11.2% were fungal or bacterial. However, in severe cases, 36.4% had fungal or bacterial infection. And in non-severe cases, only 2.4% had fungal or bacterial infection. Hospitalized COVID-19 patients are at 22% increased risk of developing sepsis and 113% more likely to experience septic shock compared to hospitalized influenza patients. Also, COVID-19 patients had higher overall inpatient mortality incidence, 15.8% versus 4.1% in influenza hospitalized patients. Hospitalized patients, especially critically ill and mechanically ventilated, are at risk for infections independent of SARS-CoV-2. Severe COVID-19 is associated with immune dysregulation, which creates opportunity for bacterial or fungal proliferation. Cytokine release syndrome, immune exhaustion, and/or lung damage may predispose to superinfection also. The immunosuppression from both immunosuppressive drugs commonly used for treatment of COVID-19 and viral infection likely increases the susceptibility to secondary infection. Extended time from presentation to appropriate therapy continues to be a major contributor to poor healthcare outcomes and proliferation of antimicrobial resistance. The current standard of care requires up to 3 days to provide sepsis ID and susceptibility results, which can delay time-sensitive, life-saving targeted treatment. Survival decreases by 7.6% during septic shock for every hour delay in time to appropriate therapy. Also, prolonged use of broad-spectrum antimicrobial is a key risk factor associated with the development and spread of antimicrobial-resistant organisms. It's also known that rapid diagnosis and treatment could prevent as many as 80% of sepsis deaths. If you look at the left side of the slide, that is the time of sample collection. And from there till the positive blood culture report, it takes between 1 to 5 days. The culture-based rapid diagnostic tests can provide species identification in 1 to 3 hours only after positive blood culture. They cannot be leveraged until culture becomes positive and also cannot be utilized in cases of culture-negative sepsis. Culture-negative sepsis is a common clinical concern where the patient appears septic, however, there is lack of pathogen growth on culture. The non-culture based tests are not reliant on culture positivity or influenced by antibiotic intake prior to the test. The Director General of World Health Organization stated that COVID-19 pandemic has led to an increased use of antibiotics, which ultimately will lead to higher bacterial resistance rates that will impact the burden of disease and deaths during the pandemic and beyond. Antibiotic prescribing in COVID-19 patients has ranged from 58 to 100%. Though concerning, widespread usage of antimicrobial therapy is understandable, especially as 25 to 70% of severely ill COVID-19 patients manifested evidence of sepsis. Also, it is difficult to exclude bacterial or fungal superinfection based on signs and symptoms, physical findings, and radiology reports. The testing population targeted by diagnostic tests in secondary infection are COVID-19 patients admitted to the ICU, COVID-19 patients experiencing new fever or deterioration, critically ill or septic patients who are negative for COVID-19, others per the high-risk factors or institutional protocols. Diagnostic testing to be impactful as stewardship tool should accurately diagnose pathogen-causing secondary infection at rapid turnaround time, enabling targeted therapy initiation on priority. Ability to more confidently stop empiric antimicrobial in specific scenarios. Also, high negative predictive value of the diagnostic test allows for consideration of de-escalating antifungal and/or antibacterial therapy in appropriate cases. Now, with this background, I will hand over to Dr. Walsh to discuss with us the crucial role of rapid diagnostics in the early detection of secondary infections in COVID-19 patients. Thank you.
Today, we will discuss the crucial role of rapid diagnostics in the early detection of secondary bacterial and fungal infections complicating COVID-19. These are my disclosures for grants and consultancies. The objectives today are to review the challenges of bacterial fungal infections complicating COVID-19 and to discuss rapid laboratory diagnostic approaches for detection of bacterial and fungal infections complicating COVID-19. Well, how may we optimize management and improve outcome of patients with COVID-19? For hospitalized patients diagnosed with moderate to severe disease of COVID-19 may have an increased risk of bloodstream infections as well as bacterial pneumonias. Timely diagnosis of secondary and co-infections complicating COVID-19 are critical for rapid implementation of defined therapies. Antimicrobial stewardship in COVID-19 is also able to contain costs and prevent emergence of resistance, particularly to our antibacterial agents. Well, What are the patterns of secondary infections? Secondary infections with bacterial, viral, and other pathogens are well described in influenza, SARS, MERS, and other respiratory viral illnesses. But by way of definition, we should further clarify that secondary infections, also known as superinfections, are those infections following a previous infection, especially when caused by microorganisms that are resistant to or have become resistant to the antimicrobial agents used earlier. A co-infection, by definition, is an infection that occurs simultaneously with the initial infection. Secondary infections and co-infections can increase pathogenesis of a given disease by increasing both morbidity and mortality of the underlying viral process. So data regarding secondary and co-infections in COVID-19 are still emerging. However, most studies indicate that secondary infections are more common, particularly in the more advanced stages. These include bloodstream infections, pneumonias, resistant pathogens, and invasive fungal infections, including candidemia, aspergillosis, and mucormycosis. To illustrate this, a multi-center analysis of the clinical microbiology and antimicrobial usage in hospitalized patients in the United States with or without COVID-19 was pursued by Posniak and colleagues, wherein between March 1st and March 31st of 2020, of 241 acute care hospitals in the Becton Dickinson Insight Research Database of SARS-CoV-2 infections in 17,000 patients, 24% were based in the ICU. 20% of those were positive for another pathogen. Among those were Staph aureus, E. coli, Candida albicans, Pseudomonas aeruginosa, diphtheroids, Klebsiella pneumoniae, and Enterococcus faecalis. Further underscoring the role for candidemia and a possible increased risk of candidemia in our COVID-19 population, Dr. Nucci compared the incidence of candidemia in two periods, from January 2019 to February 2020, which they designated as the period 1 of pre-COVID-19, and from March to September 2020, period 2, which was a post-COVID-19 period. 41 episodes were diagnosed as having candidemia, 16 in period 1, 25 in the second period. Compared with non-COVID-19 patients, with candidemia was more likely to occur under mechanical ventilation, significantly so. The incidence of candidemia per 1,000 admissions was 1.54 in period 1, that is the pre-COVID-19 population, versus 7.44 in period 2 in the post-COVID-19. This significant difference resulted in a differential incidence of candidemia of nearly 5-fold, suggesting that candidemia may be far more prevalent in the critically ill COVID-19 patient population. So co-infections in patients with COVID-19 were further explored by Dr. Lansbury and colleagues in a systemic review and meta-analysis of 30 studies, including 3,834 patients. 7% of the hospitalized patients had a bacterial co-infection, whereas a higher proportion of ICU patients had bacterial co-infections than in patients on the mixed ward or otherwise ICU settings. And that was 14% versus 4%. Among the patients who, and particularly those in the ICU setting, who had bacteremias, Haemophilus influenza, Pseudomonas aeruginosa, and Klebsiella pneumonia were the most commonly recovered bacteria. If we examine risk factors and outcomes of hospitalized patients and patients with severe coronavirus and secondary bloodstream infection in this multi-center case control analysis by Bhatti and colleagues, 375 hospitalized patients with severe COVID-19 and blood culture were collected. Within one of the institutions, T2 Candida was selected for a suspected fungal infection. 34% of patients experienced bloodstream infections during that hospitalization. of which 91% were bacterial and approximately 6% were fungal. One half of these bloodstream infections were considered nosocomial. Notably, the authors identified that T2 candidates showed value in identifying candidemia at a frequency of 42%. Among the most common pathogens there were Staph epidermidis, Staph aureus, Enterococcus faecalis, E. coli, and Candida albicans and Candida quadrata. Increasingly recognized worldwide is the emergence of aspergillosis and mucormycosis complicating COVID-19. COVID-19 associated aspergillosis, otherwise referred to as kappa, has been documented in several series. Serum galactomannan, notably, has been often negative in the early reports. COVID-19 associated mucormycosis, also recognized as PAMA, has emerged in the setting of expanded uses of dexamethasone for treatment of COVID-19. Early diagnosis of both aspergillosis and mucormycosis may be difficult, especially given the difficulty in many centers of performing bronchoalveolar lavage in critically ill patients with COVID-19. If we take a step back and reflect, what are the standards of culture-based microbiological detection of bacterial and fungal infections complicating COVID-19? We rely heavily upon direct exam and cultures of blood and bronchoalveolar lavage fluid. Typically, we would see gram stains of blood culture leading us, in this case, for example, to the right, of gram-positive cocci to a potential staphylococcal process, or calcifor white of Candida species, suggesting a case of candidemia. However, we also have seen the introduction of culture-independent tests for both bacteremia and candidemia, where we potentially can use procalcitonin, albeit not specific for either of the diseases, 1,3-beta-glucan, certainly related to candidemia, but also may be present in other invasive fungal infections, galactomannan, more specifically for aspergillosis, and mannan antigen and antibody for candidemia. PCR systems have been widely deployed, but in many countries are still investigational and still remain to be unified, standardized, and validated. Next generation sequencing of microbial cell-free DNA also is exceptionally promising, but generally utilized in a referral hospital or referral center setting. Finally, T2 magnetic resonance, which has regulatory clearance, is really among them then the only hospital-based system that recognizes organisms directly from the bloodstream. And in that regard, if we focus on T2 Biosystems, where one sees the potential for a fully automated instrument within the hospital, one can obtain results for candidemia and bacteremia, as well as for resistant organisms, within 3 to 5 hours with no sample preparation and a sensitivity for either candidemia or bacteremia to 1 colony forming unit per ml. The T2 Candida were able to detect Candida species of albicans, tropicalis, Parapsilosis krusei, and glabrata. For T2 bacteria, we can detect Enterococcus faecium, Staph aureus, Klebsiella pneumonia, Pseudomonas aeruginosa, and E. coli. And for T2 resistance, a range of different molecules, genes encoding resistance molecules, including MEK-A and BAN-A, CTXN, KPC, OXA48, a number of the metallo-beta-lactamase, including MDM, BIM, and INT, and for beta-lactamase degradation, AMP-C. So, in conclusion, we can say that bacterial infections, including bloodstream infections and pneumonia, occur in moderately to severely ill patients with COVID-19. But invasive fungal infections, particularly candidemia, also may develop in this population. And finally, the T2 biosystem may guide accurate and rapid detection of bloodstream infections, as well as support antimicrobial stewardship in this seriously ill population. Thank you.
Good morning. My name is Tamara Seitz. I'm working in the Department of Infectious Diseases and Tropical Medicine in the Clinic Favoriten in Vienna. We are taking care of critical ill COVID-19 patients since 1.5 years at our intensive care unit. And this was sometimes really challenging, so I'm more than happy to be able to share our clinical experience regarding secondary infections in critical ill patients with COVID-19 today with you. On the next slide, you see my disclosure. I have received a small speaker's fee from Biomedica, otherwise there was no financial support. I already said, taking care of COVID-19 patients in intensive care unit was not always easy, not only because of COVID-19 per se, but also because of the fungal and bacterial co-infection. In the beginning of the pandemic, there was a lack of sufficient data about the rate. There was one study reporting a rate of bacterial infection about 8 to 15%, and a really high rate of fungal infection, especially Candida and Aspergillus species. That's problematic because there is a high mortality having a secondary infection. However, the diagnosis is often challenging, and this led also in our department to an overuse of antibiotics and antifungal therapy. And this is, of course, contrary to antimicrobial stewardship program aims. So we tried to establish a diagnostic bundle in our department to be able to find the pathogen and to be able to treat it targeted and exactly. First of all, if a patient has a suspected bloodstream infection or a secondary infection, we did a blood culture, the gold standard. Then we performed an T2 bacteria on Candida panel. We were able to do it in our own point of care lab. It was in our department, so we can do it 24 hours a day, and we're independent from our laboratory. Then, if an infection is suspected in urine, a culture was done there. If patient was intubated, a bronchial lavage was done with galactoman and culture, where the D-glucan from blood, and if needed, a culture of stool as well. After 4.5 months, we did our first retrospective analysis. A total 78 patients with COVID-19 were admitted to ICU, and in 38 patients, we suspected a secondary infection, fungal or bacterial. If the secondary infection was suspected, we did the diagnostic bundle at least once. In some patients, up to 4 diagnostic bundles were performed during the stay at ICU, and we detected 67% in 67% a pathogen. And this was in over 90% of the patients at least once during the ICU stay. So if you see here, the most common pathogen, the most common infection was the pneumonia. Most of them were ventilator-associated pneumonia. Then there was a community-acquired pneumonia and a COVID-19 associated pulmonary aspergillosis. The second and the third common infection was the catheter-related bloodstream infection and the fungemia, 13%, followed by Clostridium enterocolitis and urine tract infection. Several patients developed ventilator-associated pneumonia in a median ventilation time of 10 days. The most common pathogen or detected common pathogen was a Staph aureus, followed by E. coli and Klebsiella pneumonia, then an Haemophilus influenza. In one patient, a Pseudomonas aeruginosa was detected, a Moraxella, and the MRSA. 4 patients were admitted at the intensive care unit with a co-infection with COVID-19 and the bacterial pneumonia at a median time since symptom onset of 9 days, and all of them have different pathogens, for example, the Haemophilus influenza, Moraxella, pneumococcus, and the Klebsiella pneumonia. 3 patients developed a COVID-19 associated pulmonary aspergillosis at a median time since symptom onset of 21 days and a median time since ICU admission of 13 days. All of them had a positive galactomannan. In 2 of 3, a growth of Aspergillus species in bronchial lavage was shown, and 2 of 3 had an elevated beta-glucan. And all of them were treated successfully with voriconazole and isoproconazole for 14 days. As a result of the long stay of ICU, a couple of patients developed a catheter-related bloodstream infection. One of them had a Staph aureus, one Staph epidermidis, an Enterococcus faecium, and one patient had an Enterococcus faecium and Candida albicans co-infection. 2 patients also had an endocarditis with a Staph hominis and an Enterococcus cloacae. One of the most interesting results in this study was that about 6% of the patients in the observation period had a Candida in blood. At the median time since ICU admission about 10 days, that's not so long. One of the patients had a peritonitis. That was a complication of a Clostridium difficile enterocolitis and a perforation. One patient had a cholangitis with liver abscesses, and in 3 patients, the source is not really known. All of them had an oral thrush and were treated locally. And all of them had a respiratory deterioration, and the Candida albicans was also detected in bronchoalveolar lavage. Then 3 patients developed a Clostridium difficile enterocolitis. 2 of them had a severe course with a megacolon in need of colectomy, and 1 perforation and peritonitis. And the least common infection was the urine tract infection with an Enterococcus fecalis. So now we're taking a closer look at the T2 panels. You see here, in about a quarter of the patients where the T2 panel was done, a pathogen was found. And it's much higher than compared to blood culture. There in 18.4% a pathogen was found. The median time until we got the result was 3.8 hours in T2 panel compared to 62.3 hours in blood culture. In 16.4% of the performed T2 panels, a therapy was changed, and this is twice as often compared to the blood culture with 7.3%. In the next slide, you're seeing all patients where a pathogen was detected in T2 panel. And if you're looking at the first 7, in the T2 panel, a pathogen was detected, but non-pathogen was detected in blood culture. However, you're seeing that the pathogen was detected in another specimen, for example, the bronchoalveolar lavage or the central line culture, so we can assume that it's a true positive infection. So the first patient, for example, had a suspected ventilator-associated pneumonia, and we performed the T2 panel, and Pseudomonas aeruginosa and Candida albicans was detected. Blood culture was negative. We changed the therapy and treated the patient successfully. And then in the bronchoalveolar lavage, after some days, the Candida and the Pseudomonas aeruginosa were confirmed. Patient 2, 3, 4, and 5 had the Candida albicans in T2 panel as well. The 5th patient also had an Enterococcus faecium, and in central line, it was confirmed as well. The 6th patient had also a ventilator-associated pneumonia. In T2 panel, the Klebsiella pneumonia was detected. We changed the therapy, and after some day, after we got the result of the culture of bronchoalveolar lavage, we have to change it again because the Klebsiella pneumonia was highly resistant. Patient number 7, Enterococcus faecium was detected in T2 panel. Blood culture was negative. And in the central line, a crew of Enterococcus faecium was seen after some days. Patient 8 had a Candida albicans and E. coli in T2 panel. In blood culture, only the E. coli crew. And patient 9, Staph aureus, was detected in both T2 panel and blood culture. But of course, again, in T2 panel, we found the result or got the result much earlier than in blood culture. And we were able to change the therapy earlier. On the next slide, you're seeing all patient who has a positive result in blood culture but not in T2 panel. The most common pathogen was the Staph epidermidis. 2 of them were considered a contamination. Then there was a Staph hominis and then a Bacterial cloacae. To sum up, the data of our study is limited because the observation period was quite short, but we could show that there is a high rate of bacterial and fungal infection. In our case, it was a rate about 40% of all patients admitted to the ICU with COVID-19. The data suggests that there is a benefit of additional use of T2 panel, especially in fungal infection, because it's really difficult to diagnose them with blood culture. T2 panel in label is compared to the gold standard blood culture, a more sensitive detection of pathogens, and a shorter time until detection. So we were able to change the therapy earlier and to treat the pathogen targeted. However, the blood culture and the culture of the other specimens are still needed because more pathogen can be detected. For example, the coagulase negative Staphylococcus and Aspergillus complex, and we are getting the antibiogram. Thank you very much.
Thank you, Dr. Walsh and Dr. Seitz, for the enlightening presentations. We begin our panel discussion on the topic now. Dr. Seitz, we have a question for you. Based on the preliminary data from your clinical study, could you please share the impact of rapid diagnostics T2 panels, T2 bacteria, and T2 candida on the clinical outcomes of COVID-19 patients? Dr. Seitz.
That's a really interesting question. We already saw that we used much less broad-spectrum antibiotics, and we detected more candida in blood, so we used more antifungal therapy. So for sure, we were able to use more targeted therapy. Regarding the mortality and hospital stay duration, I can't say anything because some of the patients are still in hospital, so we can't analyze the results. But I assume it might have an impact on the mortality and the ICU stay as well, not to use the broad-spectrum antibiotics.
Thank you, Dr. Seitz. Dr. Walsh, we have a question for you now. As per experience in your hospital system, what is the overall prevalence and risk of secondary and co-infections in patients with COVID-19? Dr. Walsh, for you.
Thank you for that question. The risk and prevalence vary over the course of time in patients that are hospitalized with COVID-19. We find that during the first week to 10 days, patients who are admitted with generally a wide range from moderate to severe generally have COVID-19 as the primary factor in their febrile and clinical course. There was a study conducted, for example, throughout several metropolitan New York City hospitals, reviewing approximately 28,000 blood cultures, and found that there was approximately 3.8% positive blood cultures among COVID-19 patients, in contrast to that of 7% of those who were not tested for COVID-19 and 8% of those who were COVID-19 in the same period. Again, consistent with the idea and the concept that patients initially admitted are with fever and moderate to severe infection are presenting de novo with COVID-19 and with only a minimal background of positive blood cultures. Among those with positive blood cultures, if one looks then at commensals, the bacteremia rate declined in that study to 1.6%. However, this is in the overall population. In our own experience, if you follow the patients with moderate to severe infections into the second and third week, many of whom will eventually be admitted to the intensive care unit, the rate of bacterial infections, bacteremias, and pneumonias does increase in that subset of patients. We saw, for example, among the the causes of pneumonia that patients were found to have initially Haemophilus, Staph aureus, and to some degree pneumococcus, but Haemophilus and Staph aureus were clearly present, suggesting hospital, or rather community-acquired organisms are dominating at that point. For those patients, however, who have moderate to severe, and more commonly in the severe cases, and in those unfortunate patients who are ventilated, we then see that one starts to see the acquisition of hospital-acquired organisms, including Pseudomonas aeruginosa, Klebsiella, Citrobacter, and then Acinetobacter. So in that situation, we see a shifting of the microbial pathogens from minimal to the outset, and then community acquired in the moderate to severe patients, and then finally for those patients who are often ventilated and in the intensive care unit, the emergence of nosocomial pathogens.
Thank you. And we have another question for you, Dr. Walsh. Now, how important is rapid diagnostics and non-culture based tests in detection of secondary infection in COVID-19 patients?
So particularly, thank you again for the question, particularly in the moderate to severe patients, particularly those in the intensive care unit, the ability to rapidly diagnose is critical, particularly from two standpoints. One would be for that of bacterial infections, bloodstream infections, to be able to target specific therapies to specific organisms, where we have, for example, a range from Staph aureus that would obviously require gram-positive coverage to potentially Pseudomonas, depending upon for different hospitals, that those therapeutic interventions may be certainly different from that, for example, for Klebsiella pneumoniae. The ability to be able to identify species rapidly can help target and frame specific antimicrobial regimens. But secondly, the ability to rapidly identify them and distinguish that from fever from multiple other causes is also critical, given the high degree of pro-inflammatory response in our more critically ill patients in cytokine storm. Distinguishing then cytokine storm from bacteremias is really particularly critical, and being able to recognize the presence of sepsis, intervene rapidly and promptly, because quite literally every hour delayed makes a pivotal difference in the outcome of patients by as much as 5 to 10%. So in that regard, the accuracy of diagnosis is critical. On the other side, though, there is also the role for antimicrobial stewardship, where we want to be able to target specific pathogens and not necessarily be utilizing antimicrobials in a highly pro-inflammatory setting indiscriminately. The initial empirical therapy is certainly fully justified, but then if one has the information, particularly with a high degree of specificity, as with rapid molecular diagnosis, then we're able to narrow down the spectrum to specific organisms, or have the ability to be able to discontinue and reevaluate. And therefore, rapid molecular diagnosis enables one then to be able to target patients specifically, both for improved outcome as well as for utilization of antimicrobials in a responsible and targeted manner.
Thank you. Now we have a question for you, Dr. Seitz. What are the factors you took into consideration while choosing the patient populations to test with T2 Candida and T2 bacteria panel?
The defined criteria prior to the study were a new spike of fever and a clinical deterioration or an increase of inflammation parameters, especially the white blood count, because the C-reactive protein is often elevated as well in COVID-19. But in some cases, the physician decided to do the diagnostic panel as well, even if the patient doesn't have fever, because he or she really thought that there's a bacterial fungal infection. So we run that strict on purpose. We really found the rate of bacterial and fungal infection in COVID-19 patients.
Thank you, Dr. Walsh and Dr. Seitz, for your participation in the panel discussion. We will continue to address live chat questions. Any questions not addressed due to time limitation could be sent on the email address as seen on the slide. Please also attend the poster session on T2 resistance. Thank you all for attending this scientific symposium. Have a good day. Thank you everybody for attending the session. We have our chair, Dr. Bhanu with us, and our speaker, I'm Dr. Aparna Ahuja, the co-chair, and we have Dr. Walsh here, thank you, and Dr. Holbeck, who would be, Dr. Johannes Holbeck, who would be actually fielding questions on behalf of Dr. Tamara Seitz, who is not able to be with us due to certain unavoidable circumstances. And just quickly about Dr. Holbeck, he is also in the same hospital, the specialist internal medicine and critical care at SMZ Sud, Vienna. And Dr. Sinha, Bhanu Sinha, our chair, would you want to say something? And after that, we will initiate the live Q&A in whatever time we have left. And we will also take the questions which we cannot answer right now. We will send you a response for sure.
Thank you very much. Also from my side, a warm welcome to the discussion of this session. I am ECCMID appointed chair and working in the University Medical Center in Groningen in the Netherlands as a clinical microbiologist and doing some committee work also on the national committee.
Thank you, Dr. Sinha. Thank you so much. I'll just help the speakers by telling them the questions I can see in the Q&A chat box as well as the chat box. So there is a question, Dr. Walsh, which is for you, and I would say it's for you, which is about the technology and how sensitive are the T2 biosystem panels compared to blood culture. So there are questions on what, I'm just combining 2-3 questions. One is on what method is it and how sensitive it is. So, and what does T2 mean? Dr. Walsh, you are on mute, please. Can you unmute yourself?
Okay.
Yes, we can hear you.
Thank you. We'll first address the technology behind the T2 biosystem. It's easier to understand what it would take to identify an organism in blood culture. Typically, one needs approximately 10 to the 4th to 10 to the 5th organisms per CFU per ml for that kind of detection for culture. By comparison, one can, by the molecular techniques and the unique T2MR system, one can have 1 CFU per ml, 1 colony forming unit per ml, which is exquisitely sensitive. The sensitivity is enhanced by taking the 4 mLs of whole blood, bringing it into the system, a lysis of the organism, release of DNA, and then an amplification step, which is relatively rapid, in that as soon as there is an amplicon produced that is specific for one of the 5 major pathogens, E. coli, Klebsiella, Staph aureus, Euthecium, or Pseudomonas, we then, there is a proprietary T2 paramagnetic probe which binds to the amplicon. When you have a paramagnetic probe binding to the amplicon, that then creates a change in the water configuration through a magnetic pole. For many of you, you're familiar with magnetic resonance imaging, where a magnetic field will basically alter the polarization of the water, and with release of energy, with the pole being restored, there is a burst of energy that gives a signal. That same technology that we use in MRI imaging similarly is used as the very sensitive signal, the alteration of the molecular structure of water, to give that very rapid detection, much more rapid than what you would have with a conventional PCR. So in that regard, one can see this alteration in the water structure using the paramagnetic probe through a magnetic resonance signal within the 3 to 4 hours. So it's that platform, and to give us this very unique paramagnetic NMR technology that can give us that information compared to, say, a conventional PCR system. So that's one. Two, and with that, then, how does that translate into sensitivity? If you look at the definitive, the pivotal Annals of Internal Medicine 2019 study by Dr. Nguyen and colleagues in more than 1,400 specimens, it was clear that for those organisms listed, there was 90% sensitivity, depending on how one adjusted it for blood cultures. That sensitivity, though, is also understood in that in some situations, one was even detecting more organisms than by conventional blood culture, which is always a challenge. If you have a very exquisitely sensitive system that is exceeding, quote, the gold standard, it's hard to call those false positives as well. But at bare minimum, one can say that the sensitivity was as good, if not better, and then truncated down to detection within 3 to 5 hours. That's certainly on the T2 bacteria. On T2 candida, T2 candida unequivocally detects more organisms in blood culture than blood culture. And we know from our earlier work that that blood cultures will miss easily 1/2 of cases with deeply invasive candidiasis. T2 candida unequivocally is superior to blood cultures, conventional blood cultures, in detecting significantly more cases of candida. The degree of candida really depends on the extent we've learned of deep organ tissue involvement, but certainly not only will T2 candida detect more than conventional blood cultures, but also, again, more rapidly within 3 to 4 hours.
Thank you. Dr. Horbeck, I will just mention the questions that I can see, and I'm going to combine 3 actually together. One is basically about the screening protocol that was used for the COVID-19 patients in the ICU. And these are questions which are directed towards Dr. Seitz. So basically, how did you select which COVID-19 patients to test? And also whether the T2 panels improved outcomes in the hospital. So I'm just combining two questions together.
Thank you for the question. In general, every patient that is admitted to our ICU ward, we do normal blood cultures as per standard of the ward, and also we do swab tests for multi-drug resistant bacteria such as MRSA or Enterococcus, and this is done standardly with every patient. For the T2 panels, we wanted to see if there's some sort of super infection with patients that have already got like normal spectrum antibiotic on the general ward, and we wanted to see if the patient still has another infection. So we wanted to see if we can detect it, and we wanted to know if it's obviously if we can see it in a short period. So we did blood cultures and a T2, as Dr. Seitz mentioned in her presentation. And well, yes, we saw with those patients with bloodstream related sepsis, especially with central line infections, we saw quite good that the T2 panel was superior to the blood cultures, as we saw also with Candida. I think that the major selling point for T2 is Candida, since it takes a lot of time to grow Candida in blood culture, and it's also very difficult to detect. So for the question for selection, I think that the main part was a rise in white blood cells and also a new onset of fever after a certain time, since all the COVID patients, they have fever, and some have drug-related fever for the sedation. So, I mean, the major point was a rise in leukocytes, and also if the patient already has had a course of antibiotics. And well,
Thank you so much. And Dr. Walsh, there's a question specifically for you. One is there any difference that you've seen in the, do you know about the data on incidence of co-infection, like in the low and middle income countries versus the high income countries? And what is the best approach to use the T2 panels for diagnosing these infections in the patient with COVID-19? Dr. Walsh, you're on mute, please.
I'm sorry. I do not have immediate access to comparisons of face-to-face, patient-to-patient of low and middle income to the higher income nations per se. However, I do work very closely with a wide range of colleagues and former trainees in the different countries, and have visited many countries, more than 28 countries across the world. And what I find ultimately is that when you take critically ill patients and they enter the intensive care unit, the biology starts to become very similar. The complications start to become quite redundant. The organisms may change, but given a set of risk factors, unfortunately, bacterial and fungal infections become universal. And so in that respect, targeting, especially when you have limited resources, targeting high advanced technology like T2 Biosystems to the highest risk patients, to those in whom you are likely going to have the highest yield, is a rational approach to be able to save resources. And what we have learned in the United States, and certainly in our own institution, but this has been seen in many places, is that in COVID-19, during that very early phase of the first week, that virtually all of the febrile illnesses are largely related to COVID-19. However, unfortunately, for those patients who go to unit with moderate to severe disease, within the first week, we start to see what the emergence of largely community-acquired organisms, such as pneumococcus, Staph aureus, Haemophilus, but into the second week and then expanding, we start seeing Klebsiella, Citrobacter, Pseudomonas, Enterococcus faecium. So one could envision then for the higher risk patients in resource-constrained environments that you would want to target T2 Biosystems for your critically ill patients with moderate to severe disease in the ICU. And that then, I believe, will be able to enable one to use the system, but still within a limited resource setting.
Thank you. And just for, there's a question which I would say that I would just answer. It is on what hope is there towards improving the access to these rapid diagnostics in low and middle income countries. And thank you for that question. We are making efforts to increase the access and actively working with doctors like all of you who are attending the session and the speakers on doing so. And if you're not able to answer any questions, like I mentioned earlier, please reach out to us directly after the session, and we will keep answering your questions. So till we have time, I will keep asking the questions. Dr. Walsh, there's one I would say is about how do the T2 panel support antimicrobial stewardship in your hospitals? And if time permits, Dr. Holbeck, your comments also would be valuable on this topic. Dr. Walsh, mute, you're on mute.
So, from our own experience and certainly from the literature, there's expanding experience to demonstrate, and as we heard as well from Dr. Holbeck, the potential and very real role for T2 Biosystems to be helping in the antimicrobial stewardship mission. As cases in point, when we start broad-spectrum antimicrobial therapy empirically, antibacterial therapy empirically, we are clearly covering both gram-positive, gram-negative organisms. In waiting for blood cultures, which may take 24, 48 hours beyond, and sometimes may not even be sufficiently sensitive, we often are constrained in giving extended broad-spectrum empirical therapy, particularly if the patient is improving. But with the rapid turnaround, within 3 to 4 hours, if we can narrow spectrum, for example, and knowing that we do not have an enterococcus species, we don't have gram-positive organism, if we know that we have a gram-negative pathogen, that helps immensely in narrowing our therapy down to, say, the third-generation cephalosporin, ceftazidime, cefepime, or piperacillin tazobactam, without the use of vancomycin, and thereby sparing the selective effect for Enterococcus faecium. On the other hand, if we know that we clearly have MRSA and that comes up rapidly, we can then spare the exposure to potentially broad-spectrum agents, including even potentially carbapenem. So already we can see in a relatively short span of time, and especially in critically ill patients, that we can make clear decisions along the lines of gram-positive and gram-negative organisms. Paramount, though, to our management of critically ill patients, so also is the role for antifungal therapy. And for critically ill patients, we also strongly advocate the use of empirical antifungal therapy. With that, when we suspect candida, it's often in a kind of candida. In some institutions or in lower income, low resource institutions, fluconazole may be used. Either, regardless of whether we're using fluconazole or a kind of candida, there is a stewardship component of it that the longer we will use an empirical regimen without documented infection, that we run the risk of resistance. Emergence of the kind of candida-resistant pathogens is a serious problem. The emergence of fluconazole-resistant pathogens, especially Candida glabrata, Candida krusei, is very, very well known. And therefore, knowing early that we have an albicans or tropicalis where we can rest assured that we're not looking at potentially resistant organisms is a very powerful stewardship tool. If we have negative cultures, the prior probability would suggest that that is likely going to be real given the high level of specificity. So I think in both for fungi, for invasive candidiasis, and for the common bacterial pathogens that we encounter in the critical care setting, stewardship can be enhanced by the T2 biosystem.
Thank you. Dr. Holbeck, would you be able to help us with answering this, as well as if you can manage to help us understand that you did mention about the MDR pathogens testing that is done. So if you can help us understand if you have observed higher rates of MDR pathogens in the COVID patients with secondary infection compared to non-COVID ICU patients.
Yes. I was typing in the chat earlier, but I'm a slow typer, I'm sorry. So as to MDRO patients, we did not see a spike compared to a usual population at the ICU. I think one factor of that is that we have been treating COVID-19 exclusively at our ward, and maybe it's Austrian luck. I think that we don't have that many multi-drug resistant patients in the normal general population. And for the normal population outside of COVID, this station is normally we are specialists in multi-drug resistant patients. So we get those who have multi-drug resistant organisms, and they are being sent exclusively to us. So as compared to the usual population, there is less. And I can also say that I think we have a very low number. I don't have the exact number, but we have a very low number of multi-drug resistant patients during the times of COVID for the last 1.5 years now. So by that we are blessed, I think.
Thank you.
And as for antibiotic stewardship, I think that, as Dr. Walsh also said, if you have the possibility to narrow down early with the help of T2, I think it's crucial to do that, and I think it's also saving resources and also helping the patient with, since most of these drugs are very toxic, so it's a good thing that to get the results really early on.
Thank
so
you.
Rapid testing, I think, is crucial in that case.
Thank you so much. And I think if we have a little time, I don't know whether we'll be able to finish this, but there was a question on the clinical. I'm trying to look for that. The clinical indices. So which clinical indices were used along with these panels for the prediction of the incidence of bacterial co-infections?
Yes, I see the question. So mostly, I think the one major predictor was time at the ICU and previous antibiotic therapy. Also, patient history, if the patient has been in several hospitals, I think is crucial. And well, of course, if there is if the patient had got a course of high dose cortisol or stuff like that, so that the immune system is compromised, maybe during the COVID-19 therapy.
Thank you, Doctor. Doctor, there's just one more quickly, if we can. Are there any clinical application for a negative result? Like, did you see that in the patients? Any clinical application for a negative T2 biosystem?
Yes, if we were suspecting an organism that is covered with T2 bacteria and we do the control, then we are in luck, because we can say that since the sensitivity is very high, we can say that the patient is cleared. So that was nice. And also, if the first T2 panel was positive and the control a few days after was then negative, which this was also proof of therapy for us. But if we were completely sailing in the fog, then a negative sometimes gave us a headache. So
Thank you so much. Can we still be heard? I'm just trying to confirm. Can somebody say in the chat that we can be heard? Yes. Okay. Thanks, Melissa. Basically, is something, Dr. Holbeck, you could share more on the T2 panels improving the outcomes, like you did mention briefly, and Dr. Walsh, I think this is a very important question, whether T2 panel helped improve outcomes in the facility specifically for COVID patients, since we're discussing that.
I think that one major point is that we have seen several patients with Staphylococcus aureus infection, and also with Enterococcus faecium. So with Enterococcus faecium, which is covered by T2, it was very, very good to see, and also Klebsiella and Staph aureus, of course, that there was the result early on, so we can hit them hard and don't have to be broad, because we thought maybe there was some Pseudomonas in the patient. and well, that was in this case T2 was good for the patient outcome, but well, in some cases, if as I mentioned earlier, if everything came back negative, then yeah, but I think that's the normal course.
Thank
I
you.
hope I answered sufficiently.
Yes, and if Dr. Walsh, you have any comments to make, and after that, we'll soon be closing this session.
Yes. So in a broader context, we have seen from our preliminary data improved outcome in patients with invasive candidiasis. The number of cases of COVID-19 in Candida within our institution have been relatively small. I think in part that's been related to our meticulous antimicrobial stewardship and the prudent use of antifungal agents. But in the broader context, we have seen improved outcome, and we are endeavoring to expand that database in order to fully consolidate that indeed with Candida we've been seeing significant improved outcome. And with regard to our COVID-19 patients, in general, the central principle remains, and this is across the board throughout the literature, both in the COVID setting and in the non-COVID setting. Early detection and therapeutic intervention improves survival. It improves survival for Candida. It can be measured by hours. It improves survival in patients with bacterial infections. So if we know that we have a definitive organism, whether it's in COVID or outside of COVID settings, and if we can identify those early and target therapy earlier, outcome can be improved.
Thank you. Thank you. Thank you to our chair and the speakers for all the question and answers. And we can also keep taking the questions later. The session is coming to an end. I did launch a poll, and so please answer that. That is for the participants. And I would like to conclude the session. Dr. Sinha, would you want to say something? And actually, you can also look at the poll results. And towards the end, if there's time, we can tell them, or I'll try to put it in the chat. But somehow I'm not able to send it to the chat. Dr. Sinha, would you want to say something, please?
Yeah, thank you very much. I would like to thank the speakers and also the audience for their attendance and the speakers for the contributions and the lively discussion. And I think with this, we can close the session. Thank you very much and have a nice last day of ECCMID.